So let's start the next round. Is it okay with this microphone or should I take this one? Okay, so it's too far away, the microphone, so I will use the mobile one. Yeah, welcome to the next round. We are talking about population health management and how population health management and digitalization can improve the outcome of the patients. Welcome to all of you. Thanks for joining us here in the panel discussion, and also welcome to the panelists. I'm really happy to have such a wide spectrum of participants who all have to act with healthcare and how to bring everything together to improve the patient's outcome. Yeah, what would I like to do within the next 16 minutes? First of all, I would like to give you a short overview of what is population health management all about, how is it in the US, in UK, and so on, but also some aspects regarding Germany. So how can we also kick out population health management in Germany? What is a roadblocker? What challenges do we facing with? So this will be the first 5 minutes. After that, all of the panelists will have a short statement from their point of view, what should happen to make something that is called population health management happen in Germany. And after that, we would like to start the discussion. You're all welcome to ask questions, so let us know if you have a question. I think you can use this chance to place your question. So I have this fancy presenter, not the smallest one. Yeah, I would like to start with an overview about an idea how an accountable care organization can look like. And this is a situation in some countries, especially actually in the US, where you have several actors and caregivers. And the traditional ones you can see on the right bottom side where the care is listed. So you have the pharmacy, you have the hospital, the ED department, the GP, and so on. So you're all familiar with that. On the other side, on the left side, there are the also relevant actors who try to improve the health of the patient. So there are, for example, schools, employers, gym, and so on. So they all try to work together to improve the health and care of the patient. Above that, you can see that you can make a lot of scientific, fancy stuff if you have that data together. We will talk a lot about SNOMED and so on because we have a lot of data sources and we have to find a way to bring all these data into a normalized and standardized way to make big data, artificial intelligence, and so on. So it's not only big data, it's smart data, and you need this standardization to bring that into the next generation. Oh, and by the way, I'm an optimist, so 2020 is, hopefully we can start with that in 2020, but I think it will be a challenge. Yeah, next one, it's really interesting. Actually, we are all looking on healthcare data. So we try to improve the healthcare of the patient only with 10% of the relevant data. So if you have a data set from the hospital, from the GP, and so on, this is only 10% of the whole thing. So if you can also address data like genomic with 30%, but also the behavior of the patient with 40%, socioeconomic aspects. So all these data are relevant to manage the patient health and care. So yeah, keep in mind that you can improve the quality of care to connect also these data sources and bring that into a longitudinal patient record. Yeah, this is a definition of what is population health, what does it mean? And I like that definition, but to be honest, all countries, all caregivers live that in a different way. So for sure we have several different healthcare systems. So you have to adopt it to that system. If someone is using population health management as an insurance company, you have another focus than as a research company. So population health management is about taking responsibility and for managing the overall health and well-being of a defined population. So that can be a region, that can be the members of an insurance company and so on. And they are focusing on a better outcome. So they try to bring the patient in a better health status and to decrease the cost of the patient. Initially, the population health management starts in the US, where the ACO was founded. So Accountable Care Organization, they will get money for each patient in a cohort. So they will get $600 per patient per year over the next 10 years, and they try to bring the health care or the health and care status of the patient in a better status, so the patient is more cheap and the patient feel more healthy. But this is challenging because you have seen you have to bring all these actors together so that they will work together. Yeah, that is how it looks like in the US. If you're talking about population health management in the US, and this is a pitch or a keynote from Mike Welsh. He's really interesting. He's a futurist, a global nomad, and a speaker. And he said, okay, the key for that is to centralize everything to the patient. Not only because it sounds good, it's also relevant to get all this information regarding behavior, regarding social economic aspects and so on. So you have to bring this patient into this continuum of care. And this is really impressive. There's, I think, 15,000 participants, and there was no room left in this hall. Yeah, coming back to the German market. Sorry for that, this is a German slide. But actually, we are talking about healthcare 1.0 to 4.0, and in correspondence to factory 4.0. And actually, the German hospital is something between, let's say, 1.0 and 2.0. Actually, there's a lot of processes that are driven by paper. You made some documentation, but this is only on paper, and this information is lost. So you try to bring this information together, but it's not possible. Hopefully, we start the journey to bring the hospitals to Health 2.0. Another information is really interesting, the MRAM. So there's an HIMSS stage level. So how is the level of digitalization in the hospital? And this is a, let's say, frustrating comparison. 7 is the highest level, and in Germany we're actually at, let's say, 2.2. So definitely below the average of Europe and also several other countries. So maybe we're at 2.3, but there's a lot of room for improvement, and I think we have to work on it because this is a basic. If we have this data in a structured way, then we can use it for the next steps. Yeah, some bullet points where I would like to change the health system. So actually we have fragmented patient data that are located in the at the GP, at the hospital, at your Fitbit device, at Apple Health Kit and so on. So we have to bring this data together to have not a fragmented patient data set, but to have a longitudinal patient record. So bringing all this data in a standardized way, so SNOMED, I tell you again, this is really important, and I think Professor Thun will also give you some words on that. Next one is to bring, or makes a switch from data. You have a lot of data in your EMR, in your system, but you have to shift it into knowledge. The PhD has not the time to see all this information, so you need a knowledge, not only the data. Next step is to have the change from fee-for-service, so treatment, you will earn money for treatment, actually, to the step value-based paying. I think this is a really important topic, but this is challenging. We have to change the health system. Next step is changing from reactive to proactive. Actually, we are acting in our health system if we have an incident, so someone needs a surgery. In the future, we have to be proactive to find an indicator who will become ill, who will be a diabetic within the next 2 or 3 years, and so on. So we also need this data to bring it in one data source. And the last step, perfect in the English language, makes a switch from healthcare to health and care. So you have to act on both fields. If we can do that, I think this is challenging, but yeah, let's start with this discussion, how we can get there. To get there, this is only the same picture for the German market. And to address also the German market, I have really interesting panelists here on the stage. First of all, Sylvia Thun. She is a professor at the Hochschule Niederrhein and chairwoman for the HL7 from HL7 Germany. And she's focusing on how to communicate. So HL7 is a communication standard, but also how to normalize the data we also already have, like SNOMED and so on. I'm really looking forward to her presentation. Next one is Christoph Luckmann. If you're talking about, do we have actually something like population health management in Germany? Yes, we have. Maybe you know the Gesundheit Kinzigtal. And next one is Gesundes Billstedt, where a similar project will start to also take care of a population. Second one, Dr. Sebastian Dries. He's from Philips Healthcare. He's responsible for sales development management and connected care. And he can give us some information about connecting health and how you can use that to improve the health of the patient. Last but not least, Dr. Marlis Sieburger. She's from the KfW and will give us some information regarding funding and so on, because this is really challenging. In the initial phase, you have to invest money to set up something like this. After that, hopefully we can decrease the cost for the healthcare system. So I think there are a lot of really interesting aspects in this discussion round, and I would like to hand over to Professor Sylvia Thun for her first presentation.
Yeah, thank you. I'm standing here on behalf of ZITIG. The ZITIG is the umbrella organization of standardization organizations in Germany, and it's about IT standardization in healthcare. And ZITIG is trying to convince all those players here that are somehow involved with IT projects and with IT infrastructure to use international standards from, for instance, IG, HL7, DIN, CEN, European standards, and not do it all by themselves again and again and try to reinvent the wheel. So first of all, 2 or 3 slides about population health. So what is population health for me as an educator, as a professor? It's a slightly new term, and that has not really precisely defined, but it has something about the health outcome of a group of individuals, including the distribution of such outcomes within the groups. So why are some people healthy and some people are not healthy? So this is population health about. Next slide, please. Okay. So our goal is to have an entire population health and reduce inequalities in health between population groups that can be measured by health status indicators and influenced by social, economic, and physical environments, personal health practices, individual capacities and coping skills, human biology, early childhood development, and health services. And the US spends more on health care than we do, and they have, but France or the EU has better outcomes. So the life expectancy at birth is right now at 78.8 in the US. So why? The US is focusing on a system that is very much money-driven, and here in the EU or in Germany, we are focusing on like a system that is like disease management-driven, for instance, and focusing on a medical outcome and not so much on the money. So what is missing here? Within all these outcomes, it's kind of a structured documentation, and we need EHRs, like electronic health records, to monitor and to measure all the things that we need. So, but not only in the field of the hospital environment, but within our like housing, in the housing field, and our social and social environment, clinical care and health behaviors, and here we can we have these consumer health care possibilities to monitor with my Apple Watch or something else my environment. So what do we need? We need herefore we need a standardized documentation and measurement, and we are building bricks here in North Rhine-Westphalia and in the EU and in Germany to try to make the documentation better and try to improve the communication between those who document. And one project was EPSOS. It was the European Patient Smart Open Services project from the EU within Framework Program 7. And there they standardized European health record, a patient summary, like a patient summary that can be read by all doctors in Europe. And beside that, they found out that we need a special terminology. We need something that we need a language, and this is not English, but it is a terminology that all doctors in the world can understand, and that IIT systems can communicate. This AssessCT project from the EU was about SNOMED-CT, having SNOMED-CT, a worldwide terminology for the EU. We have 27 languages in the EU. And other projects are about like medication lists or home care ventilations or diabetes care with apps. And one project was very interesting in Germany. That is Actin. This is about the emergency documentation. The triage. If you come to an emergency room, you get a triage, and this triage and the information from the triage goes into a registry. So we need registries in Europe. And precision medicine, this is Gina Lies about. So we should use those standards. I think most of you know these standards, and I just point out that here IHE can help us a lot in many fields, but we have to use them and understand them. That's from me. Thank you for your attention.
Yeah, my name is Christoph Luckmann. I'm IT leader at Gesundheit für Billstedt, and I'd like to tell you something about the population we are already managing and the IT systems we use and that we are going to use. So the project in West is takes place in the east of Hamburg. And there are social disparities in this region. The life expectancy is 12 years lower than in the west of Hamburg, and the social status is much lower than in the west. We do have many people living there with migrant background, with bad education, unemployment. Yeah, that's what you can see in Horn and Billstedt, and and you can see in Hamburg. We have lower education, unemployment in Billstedt and Horn. And so from the data, that's the first step. So we began the project that we analyzed the data together with Optimedes. And we've seen that people get ill 10 years earlier and that they also die 10 years earlier. And we have higher disease prevalence and lower health literacy and a growing population and and limited mobility. And the result is that there's a low concentration of physicians compared to the rest of Hamburg because there are financial disadvantages and just a few private patients. There's a high workload for the physicians. It's very time consuming, also because there are language barriers and cultural and communication problems. And Yeah, as you can see, the average costs are very much higher in our area compared to the rest of Hamburg. And yeah, we are working on, so that's our business model, that we try to reduce the costs in the east of Hamburg. And these savings we share with the health insurance. Yeah. So what we have to do is to reorganize the healthcare system and meet economic and social challenges. So what are we doing? Our vision is that we want to reduce the inequalities between the east and the west of Hamburg. So we got different interventions. With that, we are working on it. We want to strengthen home care. So we build up programs for chronic disease patients and implement care pathways, set up a day hospital, and ensure drug safety. On the IT focus, we integrate mHealth and eHealth solutions, an electronic patient record, and we use innovative technology from a startup company. And we link, I think that's very important, we link the health and the social care. And we set up a walk-in clinic, we call it a health kiosk. And yeah, so there we manage our population. And we got a strong cooperation with the social and nursing institutions, so we can send the patients to the social institutions that are already there in the area, and we can help them to find the right institutions that can help them. Yeah, the walk-in clinic, it's a new part we want to introduce to the health system. It's a low threshold and supportive institution for all health-related issues, with the aim of improving population health through a needs-oriented and integrated continuous health care. And yeah, we provide the help in mother tongue, and yeah, we get 7 people working there. Everybody speaks a different language because, if you've seen it on the first slide, we got many people with migrant background. Yeah, just to look on this short, it's yeah, we prepare consultations with the patients so that they are prepared when they go to the doctor. And also after, when they come back from the doctors, we help them to understand what the doctor said and what are the next steps. We are networking with these social institutions, and we're working on case management so that we also can help people at home and lead them through the system. Yeah, what are our IT solutions? Yeah, first have a look at the starting point. Our physicians use 20, or in this area, the 20 most used electronic health records are incompatible, so the physicians can't share any data. 78% of the people would like to use mHealth, but there's also the problem that we don't get the data into the electronic health record. Then next year starts telematic infrastructure. That's very much work for us, but yeah, a poor benefit for the physicians. And yeah, there are thousands of apps that might be used, but we also got to look what really fits to which patient. Yeah, that's the other thing. We're still working with paper, and we've got these tiny card. Yeah, that's a starting point of digitalization. Yeah, what are we doing? We have a partner, Connected Health. They have these lifetime apps, so every patient can download this app for free. And the doctors have these hubs, and they can share the data with the patient. So the patient has his mobile phone with him, and so then they're able to take the data and take it to the next physician, and also bring the data to the health kiosk, so that we can explain what these informations in this record say. With the electronic health records we are going to implement, we want to connect the app data. We want to strengthen the teamwork and also use telemedicine and online services. And what we already do is that we collect from every patient, we take an anamnesis formula and collect the data structured and so we try to understand what kind of populations do we have, where are the high-risk patients, which programs work with which kind of patient. But as we just started this year, we are still at the beginning. And we are working on outcome data. We got data from the health insurances, from the physicians, from hospitals, and as I said, from the health kiosk. And we've got our shareholder, Optimedes, who provides data cockpits for the physicians, systematic feedback so that they can see what they prescribe to the patients and what might be better. And we've got information for case management. We can give quality feedbacks and potential analysis so that we know where we start our programs. And then they calculate the data for us and we play it back into the area. Yeah, that's what we do.
Hi there, I'm Sebastian Dries. I lead Connected Care for Philips in DACH, but first want to start out, of course, with a global picture of what population health means to us and how we can contribute to simplifying the transition of our people and our customers, so payers and providers, to continuous longitudinal care. We usually picture this in a health continuum, what you see at the bottom of this slide. So people start being healthy, then they might get ill, they need a diagnosis, they might need a treatment, they hopefully recover well, they might end up in care, but they might also return to a home in a healthy state. So this is what we call the health continuum, and we want to serve the providers and the payers in being the best partners for these people, if they are patients or insurees or just citizens, to guide them and help them in their health journey. So how to tailor and how to enable an organization to do that. These are slides of a company that we acquired last year. It's called Wellcentive, and they very much enhanced our strategy on population health management. So they are rooted in the US, which means that they are driven by the incentives of the meaningful use generation of acts and implementing, enabling integrated payers providers, so integrated delivery networks or accountable care organizations and the like, to perform better against the outcome quality parameters. And there are 4 levels of engagement that they have seen, and this is kind of the guideline that we are also using to internationalize these paradigms. The first one is organizations are able to understand what matters to their population, how their population is layered, what people are in there. The next level is to be engaged with it, so to navigate, to enable people to steer these populations and to allocate meaningful interventions to them. The third level of being coordinated means that you can also activate people, that people take part in their care, and that the organization has means to digitally interact with individuals that they care for. And the fourth level, that's being a high-performing, closed-loop, quality-driven organization, which means that they have implemented all the means of empowering people also to self-act and enhance their care. What's in the black box? What's behind it? Of course, there is a massive data processing chain, if you will. So there is a mechanism to ingest data from various sources, to normalize this data, to embed it into workflows, to make it actionable, so to aggregate it, but also to use information that informs on next steps, to guide intervention decisions, to guide testing decisions, etc. And then it goes back to accountability. So how do we act upon this? How do we improve our workflows as an organization? This is then closing the loop and, of course, reporting on it. What does it take an organization to go this transformation route, and what do we deliver to enable them? So of course it's first an assessment, then it's implementation of meaningful tools which enable them to really reach out to people, to implement the initiatives, and then they can continuously improve. That's kind of an engagement, so it's not a software sales engagement, it is really a solution that transforms an organization to be an outcome-driven organization in the end. Just some proof points maybe to kickstart the discussion that we'll have in a minute. So in these three pillars, what you see on the left, that's more a population health management kind of proof point. It's on corporate health management, and it's more general indicators that have improved for an organization that takes care of a big group of employees. The middle column, that's more about chronic care. So there it is about telehealth for the health of people with chronic conditions, remote home monitoring, where it is, for instance, a key indicator to save on transportation costs and to save on acute hospitalizations, which can be mitigated by proactive ambulatory interventions. And the third one, that's about care, so that's more in the nursing care realm, where it is about predicting deteriorations by the means of how people behave, how people are active, and avoiding hospitalizations due to falls, for instance. So those are our proof points from different fields, and I'm happy to engage in a discussion with you and the panel. Thank you.
Hello, my name is Marlis Sieburger. I come from a quite different environment from a bank in Frankfurt, KfW banking group. And so I also will introduce to you a totally different perspective, because my field of work is development cooperation with funding from our German government, and definitely we seek to find the best solutions to tackle the problems we find in our partner countries. So digital health is definitely on our agenda, because we feel that the challenges we face can be addressed by applying digital health. And just to give you an idea where I come from, KfW Bankengruppe, maybe most of you know it from housing financing, from promoting the German economy. So also in promotion of German economy, there's a lot of discussion of digitalization and how we can, as a German promotional bank, assist our government in bringing this forward. But I'm from the international part, and there also we have a institution for export and project financing. We have also another institution dealing with the private sector, and I'm very happy that a colleague of DEG, the private sector arm of KfW Development Corporation, is here. And I'm from the field where we work with public institutions in the framework of intergovernmental cooperation. So agreements between governments on how to support the development of the health systems in our partner countries. I must admit that it's rather a small share of our overall commitment of the KfW Development Bank to developing countries. Only 3% last year went to health programs, but we still think it's a very important area, and we also feel that in development cooperation it will become even more important as countries develop. So the aim is over-ambitious, universal health coverage, and it's not just a comparison between Horn and maybe Blankenese on the other hand in Hamburg. It's really about Germany and Nepal or Tajikistan, where we try to reach a more equitable service for healthcare for the populations. I will skip the organizational structure, just a view on where we are active in my team. We tackle quite a lot of different countries, which from Afghanistan with a very low income level, and China on the other hand, where we work with promotional credits, with very sophisticated health systems on the other side. And I just want to introduce to you 3 examples. So let's move forward. We look at Vietnam, Nepal, and Tajikistan, and we have some general data here. Why exactly here we think it's a very important role of digitalization in the health system. So what you see is in the IT system, mobile cellular subscription is not so much different from what it is in Germany. Internet usage is, and definitely there also some improvement will come, but also maybe they skip some of the developments we have here. And why should we employ e-health or digital health in these countries? Because we have extremely limited resources in the health system as such. Yeah? So to pick just one figure, the health workforce, when we have 99 proportion of births attended by skilled birth attendants in Germany, it's only 87 or even 48 in Nepal. So that means more than half of the women in Nepal give birth to their kids without any skilled birth attendant. Or if you look at the financial resources, it's also pretty much clear that if we have a health expenditure per capita of more than $5,000 in Germany, in comparison to 140 in Vietnam, or even 76 in Tajikistan, or 40, we work with extremely limited resources. So we need the efficiency of the digitalization to bring at least some services to the people on the ground. So this is just to give you a background what we are working on. So in the later discussion, we can bring this in. In Vietnam, we try to install a network for emergency care by using internet connections between the central hospital in Hanoi for surgery, the Viet Duc hospital, and linking them to the provincial level, and from there downwards to the regional and the district hospitals. On the one hand, to give training via these internet connections, but also to give consultancy as a second opinion or something from the very central, most sophisticated level to the district level on the ground. In Nepal, we try to improve maternal and child health in the very remote areas, and we also assume that if you see on the right hand the zonal, the regional, the district hospitals, but also primary health care centers and communal health workers, by linking them via mobile phone, we can improve the situation a lot. In the session before, we learned that in our industrialized companies, a lot of people come to the doctors and think about risks, and it would be unnecessary. In these countries, the people do not see a doctor, although they are at very high risk, and we want to change that situation. And my last example is in Tajikistan, where we have a restructuring of the hospital setting, also again to improve maternal and child health, but also emergency care, and trying to, while refurbishing hospitals, bringing in new equipment which can be used by internet, also link these hospitals one to another, and from the central level to, again, provincial and district level, to improve the care at the very last area in these countries, which is then also a district hospital or even a primary health care center. So these are the examples I wanted to bring forward to you. I understand it's quite a different perspective, but I'm looking very much forward to our discussion, and I hope that I can get a lot from my colleagues, as I did already from their presentations, and maybe we can also bring in some experience from these partner countries to then develop further the ideas in Germany. Thank you.
thanks to all of you for your presentation. We are running a bit out of time. So most important is if you have a question to the participants, so please let us know. Then you can place your question. I think we have a really wide spectrum of knowledge. So if there is any question.
My question is related to the persons behind the equipment you use, because I think there are wonderful things which can bring us forward, but we need that the people accept this kind of work. I don't know, perhaps in Billstedt and Thun, that you explain how this is, or Mrs. Sieburger, and what happens in Asia, because the patient must accept that and must be willing to take responsibility for his life. And this is a key issue underlying this.
Yeah, what we can see is that we get to educate the people in using the apps, for example, and to use the electronic health record, and that it's not even, if you think it's intuitive, yeah, that you can just use it, maybe it's for digital native, it is, but for the normal user or patient, it isn't, and that's what we see, that we got the, the equipment, but that it's not used as much as we want to be used it.
And in my opinion, it has to be interoperable, so that you don't have to put in your data in one application and the next apps, and the next doctor asks you again and again about your laboratory test results or something. So try to achieve this.
Yeah, and I would also add that we have a chance in the developing countries, as I said, to skip some of the developments we have here, and also to have some pilots in areas where there is less concern on data security. Not that I'm arguing that we can use everything everywhere, but to try something out, there is some preparedness in a very resource-limited surrounding, because they just have no other chance.
Perfect. Any other questions? If not, so I will have some more questions. Professor Thun, so actually we don't have SNOMED CT, so one really important normalization catalog in Germany, but we also don't have LOINC really in use. We have a lot of structured data regarding paying in Germany, but not the healthcare related data. What's going wrong? What can we do to change that?
SNOMED CT and LOINC are like universal languages that doctors use all over the world, and we need a language to communicate. So the problem that our government didn't face this problem yet, like the semantic interoperability issue, and our industry didn't neither. So we have to have a clear strategy from the government and from the industry to go toward the international IT standards and go toward WHO languages and other languages that are very in common, so that we can have this data at some point. So doctors don't have to do so much data input in the one hand, and on the other hand, we can analyze data. Right now, we cannot analyze data because our data is unstructured, and we cannot participate in international networks. Like for the genomic parts, yeah, we have huge networks for genomic testing, reporting, and the analysis of genomic data to have a better treatment for cancer patient. So we cannot participate, and this is a very important issue, to have a license for these languages and to use these languages and to have a strategy for these languages.
So maybe to also underline that, actually, if we are looking to other countries, this is a challenge only in Germany. So in all other countries, we have that SNOMED, LOINC, and so on, and this is really, let's say, this is pain that we cannot use it in Germany, because we have a lot of scientific research departments and so on, and they can all make really great development, also not for Germany, but also for other countries. And this is also a business. Not only it's helpful for the patient, it's also helpful for the industry. And can underpin that and underline that this is really important. So yes, thanks for that statement. Someone else would like to answer to that? Or? So maybe one additional question, Mr. Luckmann. Mr. Hildebrand mentioned that he needed a key integrator for a structure like that. So someone has to take the role for the integrator to bring the GP, the hospital, and the patient together, to work together. What is about Hamburg? What are you doing on that point?
Yeah, we are this integrator in Hamburg, as it is in Gesundes Kinzigtal. Yeah, we have different ways to integrate. One thing is that we integrate the interests. So that when we that the financial benefit will be bigger when the patient is healthy and when we reduce the cost. And that's, yeah, and because the doctors and physicians, they participate or are shareholders at our company, so they have an interest, yeah, we get these interests together in the area. And we also, yeah, we are a platform. Normally physicians are working on their own and often don't know maybe the other physicians just a few kilometers away. And now, since we are building up this platform, it's interesting to see how they connect and how they yeah, exchange information and yeah, are talking about the processes.
Thank you. So we'll have a look on the time. I think we have 5 minutes left. But I would like to also ask Dr. Sieburger, what is about Germany? Can you also make some investments in Germany driven by the KfW to, let's say, given funding for a health region or something like this? So the key integrator.
As I said, I mean, the role of KfW within Germany is also to promote political issues that are at stake for us, and there is at the moment a lot of discussion on digitalization and how this can be financed by promotional loans which are handed out over the banking system here, but they get the subsidies at the KfW center, if you want, as such. Yeah? So if our economic minister of the future or the health minister, they come together and they want this development to be financed, they can come to KfW and we will deal with it. But so also I see from Hamburg or from Kinzigtal, you need some politicians which are willing to implement this, as we do in our partner countries. Yeah. So if in Nepal there's a decentralization going on, and there are some people which see this as a chance to change their structures, we have a chance to move this forward. That's the same, I think, here in Germany. And if the politics are willing to change it, KfW as a promotional bank is on their side. Yeah.
So maybe last question to Dr. Dries. Yeah, you're working for Philips and you're actually developing an EMR and also active in the PHM environment. Let's say in Germany, actually the IT investment is, let's say, a cost center. It's not only to find a way to reduce costs, to optimize the workflow and so on. So what do we have to change in the German market that IT is a core element to find optimization, not only that it is a cost center?
I think it's all about demand and driving a need for change, not only with organizations, but also with people. So we talked about what engages people. Of course, it has to be surprisingly simple and to solve a job to be done for them. So if a health app or a chronic care management system user interface for a patient is engaging, that they use it and they ask for it, then providers will orient themselves to offer this kind of service. So that's kind of our approach, and indeed the strategy to enter Germany with these propositions is almost the other way around than for the US, because for the US quality comes first, it's mandated quality indicators, and here it's the other way around, it's more care provision driven. So we first need to activate people and then measure what does the navigation about this activation help, so then understand what are we doing and then prove and then close this quality cycle.
So that's a bit the interesting bit. And well, how do we do it? It's enabling people to utilize the health system in a digital way. So it's for people, we will provide electronic health, personal health records. It's a bit of a numb term because it sounds like the folder that you carry around with all your chronic condition information. It's really more about a health system utilizer app that we will provide there. And insurances are driving the demand for this. So you will know of several projects where insurances already procure such a solution, and this will just grow over the next 1 or 2 years massively. And the other way is for the providers, so enable them to reach out to people digitally, provide patient portals, not only for scheduling and things like that, but also for engaging in workflows about their care. So that's kind of the strategy how we approach it.
Perfect. Thank you. So I think we have only some minutes left. One final question or short statement. So you have a lot of interesting actors in the healthcare market, but also patients and members here in the auditorium. Can you give us one statement? What do we have to change in Germany to improve the health and care in the German healthcare system? Maybe we'll start with you, Sylvia.
We have to have stronger responsibilities and a strategy.
From the IT focus, I would say we need law that allows a regional management company like we are, that we collect the data, even from health insurances, from electronic health records, and that we are able to collect and analyze the data.
I would say what we need is nurture the demand to be motivated and engaged about own health and create showcases how to use it, because all the political stuff is there. We have the innovation fund, we have an e-health law, we have lots of things that actually allow stuff, but stuff isn't done because the incentives aren't aligned for it. So if people drive the demand with their feet, then I think that's what I'm looking for.
Yeah, and for these people, it needs a bit of courage and a bit less skepticism, because as always, we try to analyze everything until the very end, and only if everything is proven as when you outline what the change is until it actually can come into being. So we also need to leap forward and to jump on the chances rather than always see the risk that might occur if using these apps and things. And I hope there are a lot of people willing to do so and moving this forward, as you said.
Perfect. So at the end, thanks to you that you can bring really interesting information to the auditorium. Thanks to you to join this meeting or this discussion. Have a great day at Meineke, and I think the next dialogue will start within the next minutes, so please stay here.